Well, welcome everyone. I'm going to go ahead and get us started so we can move ahead with our day one of this symposium. My name is Heather Gotham. I am the director of the MHTTC network. That's Mental Health Technology Transfer Center. That's an acronym for you, and we'll explain that in a minute. I'm the director of the MHTTC Network Coordinating Office at the Stanford University School of Medicine, and am pleased to open our first session in the Organizational Wellbeing in Healthcare National Symposium. I want to thank all of our wonderful speakers for being here with us today and tomorrow, and give a big thanks to all of you for joining us. We really hope that you find today's sessions and tomorrow's sessions engaging and helpful in your work. So for today's presentations, we're going to try to increase your awareness and understanding around the need for systemic organizational well-being approaches within healthcare to address the critical issue of professional burnout. We certainly have seen in the past year and a half with COVID that this has become even more critical, but we also want to recognize that the issue of professional burnout within healthcare and behavioral healthcare is a constant issue. We're glad to highlight this today and tomorrow. Next slide. Disclaimer that we are funded by the Substance Abuse and Mental Health Services Administration. The content that we're presenting today is our content, and the views expressed herein are the views of the speakers and don't reflect the official position of the Department of Health and Human Services, or SAMHSA. We are excited to welcome Dr. Miriam Delphin-Rittman as the new SAMHSA Assistant Secretary. Next slide. For housekeeping, a few items here. We've made every attempt to make today's presentation secure. If something happens and we need to end the presentation unexpectedly, and I'm talking here about Zoom bombing, we'll follow up with the registration information. Folks are muted today and can't share video, but we really welcome a lively chat. So go ahead and use the chat for comments or links for all attendees. If you have a question for the presenter, please go ahead and use the Q&A pod. At the end of today's training, we're going to give you information about a really brief survey. We would love to get your feedback about how today went. So please look for that at the end of the sessions today. You'll get an email on how to access a certificate of attendance within the next week. You need to attend at least half of today's programming in order to receive that. We've got closed captioning on if you need that. You can find it at the bottom of your screen. There's some information now in the chat about that. And please follow us on social media. Let us know, again, how we're doing and what we can do to make this content more appropriate for you and your needs. Next slide. So I said we've got quite a name here, Mental Health Technology Transfer Center Network. The technology transfer in our name really doesn't refer to hard technologies. We're talking about innovations, technologies, evidence-based practices for mental health and behavioral health. And our network accelerates the adoption and implementation of mental health related EBPs across the nation. So we develop resources, we provide free local and regional training and technical assistance like today and tomorrow, and really try to heighten the awareness and knowledge and skills of the mental health workforce. Next slide. Here's a map of our network. Oops, go back one. Thank you. Map of the network. So our network consists of 10 regional centers. So go ahead and find your regional center based on the map. 10 regional centers and 2 national focus area centers for specific populations. One is a National American Indian and Alaska Native MHTTC. The other is a National Hispanic and Latino MHTTC. And as I said, I'm from the Network Coordinating Office. So again, please find your center based on where you live, and you're going to want to connect with them. If you go to our website, you can go to their specific website and find out about free training and TA in your specific area. We also, like today, have things that are happening nationally. We invite you to join that as well. Next slide. This is a 2-day symposium. Today, we're going to hear from Doctors Grace Gengoux, Ashley Stewart, Colin West, and Lauren Pecoraro. Tomorrow, we'll hear from a panel of well-being experts and work on strategic planning within organizational teams. We're going to start today. Next slide. with our keynote, System Solutions for Enhancing Professional Wellbeing with Dr. Grace Gengoux. Next slide. I'm thankful to welcome a fellow Stanford faculty to be doing the keynote this morning. Grace is in the Department of Psychiatry and Behavioral Sciences at Stanford University. She's co-authored a book focused on professional well-being and practical strategies to promote resilience for providers of mental health care. In her work as the department well-being director, Dr. Gengoux leads a task force charged with developing solutions to combat burnout by improving efficiency of practice and cultivating a stronger culture of wellness in our Department of Psychiatry and Behavioral Sciences. She's also a licensed clinical psychologist with expertise in naturalistic developmental behavioral intervention for children with autism spectrum disorder. She serves as associate editor for the Journal of Positive Behavioral Interventions. Dr. Gengoux received her PhD in clinical psychology from the University of California, Santa Barbara, and completed a clinical internship and postdoc at the Yale Child Study Center. Thank you very much for being here with us today, Dr. Gengoux.
Thank you so much for having me. I'll just share my slides here and go ahead and get started. Well, welcome to all of our attendees. It's so exciting to be here with you and to kick off what promises to be a wonderful symposium. Thank you, Dr. Gotham, for the wonderful introduction, and I'm pleased to talk with you about a topic that I'm very passionate about, the idea of system solutions for enhancing professional well-being. And I know many of you are here today because you're passionate about supporting the well-being of your employees and your colleagues in healthcare. And I hope what I can do today is share some of what I've learned over the last few years of studying this topic and being a well-being director in our department at Stanford, and also share kind of an emerging consensus that has come from many institutions across the country around what systems need to be doing to support the well-being of their clinicians and healthcare providers. I'll share a little bit about what Stanford is doing. I'm lucky to work in an institution that has tremendous leadership in this area. And so I'll share what I've been learning there. And I'll also share some of our own kind of on the ground experience, lessons learned, and resources that our department has found useful as we've tried to take action on these important topics. So to frame our discussion today, I want to acknowledge three kind of hard realities that are probably on your minds, and they're on my mind as well. One is, you may have seen at the beginning of the pandemic, people quoting things like this on Twitter or something, the idea that we are not all in the same boat, but we are in the same storm. And I want to kind of flip that and say, we may all be in the same storm, but we really aren't all in the same boat. And as we kick off our conversation today, I want to acknowledge that we've all had really diverse experiences over the last 18 months. Many of us have experienced substantial professional or personal loss. We've also, of course, equally true, seen tremendous generosity and heroism and resilience. But as you listen today, I hope you'll be inspired. And I also hope that you'll be kind to yourself. As healthcare clinicians and administrators and leaders, we often have very high standards for ourselves. And each of us comes today at a different place in our own life journey. And given the current circumstances, whatever it is that you're doing the best that you can is really quite impressive. So let's all practice that self-compassion that we know is so important and that we teach. A second thing that I want to acknowledge is that when we talk about wellness, this actually means something different to each of us. And we have to be actually fairly careful when we think about rolling out wellness interventions, that these don't actually become another way to reinforce ableism or problematic systemic discrimination, another way to expect perfection from ourselves and to fail to meet the high bar that we set. So as we think about wellness, we're going to talk about how wellness is a process of diversity, of inclusion, and of keeping our minds open for the many, many ways that people from different backgrounds pursue their own personal and professional well-being. And finally, to kick off what I hope will be an otherwise uplifting and inspiring talk, I want to acknowledge a hard reality that faces our physician colleagues and healthcare professionals, and that is the problem of suicide. We've known for a long time, for instance, here's some data from a colleague and leader at Stanford, Tate Shanafelt, and his colleagues who published in 2011 a study looking at suicide, rates of suicide in surgeons. And you can see that while about 15% of surgeons surveyed had thoughts of ending their own life, and about 8% or so had sought psychiatric help in the previous 12 months, it's quite troubling to see that almost 40% of these surgeons were reluctant to seek help for depression because of repercussions for medical licensure. And although that medical boards and psychology licensing boards across the country have been reconsidering how mental health history should be reported in licensing applications and renewals, there's still a lot of work that needs to be done in this area so that there aren't these kinds of systemic barriers to help seeking for our own people. Here's a more recent study published just this year with also Dr. Schonefeld's and colleagues like Dr. West, who you'll be hearing from later in this symposium, and Dr. Trockle here at Stanford as well, looking at physicians across the US, showing that 1 in 15 US physicians had thoughts of taking their own life in the last year. And that exceeded the prevalence of suicidal ideation among US workers in other fields. And the presence of suicidal ideation seems to be a risk factor for limiting help seeking. So I want us to all be mindful of these serious issues as we delve into our conversation today. I'm going to try to cover 3 objectives as we talk. First, I want to justify the need for systemic approaches to well-being for healthcare professionals. And then I want to introduce Stanford's WellMD model of professional fulfillment in case this is a model that might be useful to you in your organization. And then I want to describe some practical strategies for enhancing connection and flexibility and professional growth in your organization. And I'm going to try to cover a pretty wide range of strategies, both those things that individuals can do with relatively few resources who are working in a grassroots way to try to inspire change and progress in their organization, but without substantial institutional commitment. And then I'm also going to talk about these emerging best practices for institutions that are ready to make a much more substantial institutional commitment. So wherever you're at, I hope you'll hear something that will be useful to you in this discussion. So burnout is a concept that has been talked about for a long time and kind of classically defined as this combination of emotional exhaustion, the sense of feeling just drained and empty of ability to kind of commit or engage emotionally, depersonalization, so this sense of distancing or disengagement from the work or the people that we interact with, our patients and colleagues. And finally, a perceived lack of personal accomplishment. It's not an actual lack of personal accomplishment so much as the sense that nothing that I do is making any difference. And together, these 3 form a syndrome that we consider burnout. And as you know, the problem of clinician burnout is increasingly recognized in medicine. Here are some data from over the last decade documenting how physicians have higher rates of burnout consistently when compared to the general US working population. So data from 2011, 2014, and 2017 show in the blue line here at the top, physicians consistently more burned out in the 40 to 50% burned out range across this period of 6 years. And similarly, less satisfaction in the blue line here at the bottom with work-life integration. And this is troubling. As Dr. Gotham mentioned, this is a problem that we've known about for some time and was definitely in place well before the pandemic. But of course, now we're talking about an additional tremendous burden on our healthcare workforce in responding to the pandemic, both the acute and direct consequences of COVID-19 and also the mental health consequences. And therapists and mental health workers and clinicians of all kinds have faced an incredible hardship over this last year. And this is one of the reasons that our topic is so important today. I want to frame this, however, with an important caveat that resilience is actually higher in physicians, and healthcare workers tend to be highly resilient. And so this is, I'm looking at data here from my colleague, Dr. West, who and his group, looking at no matter how high the resilience scores are in the physicians that they surveyed. So even these individuals all the way at the right-hand side of your screen who are showing the highest level of resilience, they're sort of topping the charts in terms of resilience. We have 30% of those physicians are still reporting burnout. So this tells us that this is not a problem of the individual physician. This is a problem of the system. The burnout is not the fault of an individual. We need system level solutions, and everyone can help. And that's the spirit in which I share the information I have for you today. Here's another really important publication. If you haven't read this paper, it's really a great one to check out, by Schonefeld and Noseworthy, published in 2017, talking about executive leadership and physician well-being organizational strategies that promote engagement and reduce burnout. So they've identified some key driver dimensions. Many of these are actionable for those of us in healthcare leadership positions. Things like the efficiency and resources, things like workload and job demands. The more we can increase control and flexibility, the more we can tap into meaning in work. These are all things that are going to drive dedication and engagement. And when they're not in place, when we have a problem with organizational culture and values, with work-life integration, with a lack of social support and a lack of efficiency, we see more cynicism, more exhaustion, and more burnout. And finally, I want to share a little bit about the business case for improving well-being of our healthcare workers and clinicians. Burnout and turnover have direct financial costs to healthcare systems. A few statistics here that you might find interesting. Physicians with burnout in this study by Miriam Hamidi and her colleagues showed a 168% greater chance of leaving their jobs within 2 years than those physicians who were not burned out. The cost of replacing physicians has been estimated to be 2 to 3 times the physician's annual salary. And also, physician turnover and reduced clinical hours could cost up to $4.6 billion annually, and that's about $7,600 per employed physician. So tremendous cost. And these statistics cover the case of burnout, driving turnover, leaving the workforce, but they don't even cover the cost of medical errors, which are more common in burned out physicians and burned out healthcare workers. And And so the errors that might cost an organization financially, as well as the decrease in quality of patient care. There's consistent relationship, positive relationship between physician self-care and well-being and the quality of the care and the advice that they give their patients. So these data have been a major driver in a movement that's been happening here at Stanford, as well as in many institutions across the country, to really escalate organizational commitment to well-being efforts. So a few years ago at Stanford, Brian Bowman and Tate Shanafelt was brought in to found the WellMD Center. Mickey Trockle, my colleague, is leading the research efforts in that institute, and we have tremendous leadership across the institution, putting together resources both internally and also for our colleagues across the country about wellness and well-being interventions. And I'll talk about this later, but the tremendous institutional commitment that's required started really with identifying a chief wellness officer and bringing the well-being initiatives in Stanford really to the top of the charts in terms of this strategic plan, embedding the well-being efforts right into the strategic plan of the organization, up there with things like patient safety and quality of care, and the financial goals of the institution. And this is one of those things that has become an emerging best practice, is to have the top leaders in our hospital and in our system accountable for clinician well-being, just the way that they're accountable for things like safety and a financial contribution. Stanford uses this model to guide their well-being efforts. And maybe some of you have seen this already, but I find it quite helpful. It's useful to notice actually at the center of the model is not reducing burnout. They've actually put at the center of the model the concept of professional fulfillment. And that's a good reminder that we are trying to not just avoid burnout, we're actually trying to increase the sense of professional contribution and effectiveness, engagement, and fulfillment. And then there are three key drivers of professional fulfillment. Now, the one at the bottom here, personal resilience, is really the one that is the responsibility of each of us individually. There are things that we, as individuals can do and should do to drive our own personal resilience. Things like getting enough sleep, like having social connection with people that we love, eating well, getting exercise, these sort of simple self-care things. And each of us bears some responsibility for doing that. But really importantly, this is a fairly small piece of the pie, because the other things that drive professional fulfillment are systemic issues. And these are things that one individual cannot change on their own. The efficiency of our practice really drives professional fulfillment. Honestly, most of us are just coming to work, trying to do our jobs. And if there are big or small hurdles in the way that stop us from providing the quality care that we want to provide, these small or big obstacles can really erode our sense of well-being and professional fulfillment. So to the extent that we can improve the efficiency of practice, well-being for our colleagues will go up dramatically. And similarly, a culture of wellness is an important concept that all of us contribute to. There's no one person who's going to be able to drive an organization's culture of wellness. This is, we all have a stake in this piece of it. And it needs to be, this is a slow and probably difficult thing to change, but this is an important objective where we can all try to work to make sure that it's okay to take time off, it's okay to take care of yourself, and really believe that the quality of the care that we're providing is better when we are more well ourselves. There's another framework that's also useful for thinking about systemic approaches to well-being. We can think of it as a kind of in a similar kind of primary prevention model, where there's a tier 1, where we're trying to prevent burnout across an organization. So working on things like efficiency of practice, making sure that we have good systems for taking vacation and time off, where there's cross coverage, and making sure that the team culture and camaraderie is strong, that there's psychological safety in our meetings, and that it's okay to report mistakes. All of these things, there are lots of things we can do to sort of prevent burnout at the tier 1 level. Then above that, we need to be sure we have systems in place for identifying and supporting professionals at highest risk. So a lot of times this includes assessments and also includes more targeted interventions for specific individuals. For instance, at Stanford right now, we're in the process of rolling out better lactation support for breastfeeding people. And that would be an example of a tier 2 intervention, which is it's going to affect many of our colleagues, a subset of our colleagues, and will be an important preventative sort of secondary prevention measure. And then in tier 3, this is where we need to have focused interventions for providers who are experiencing burnout or who have experienced adverse consequences, maybe because of medical errors or because of some other event. And so here we need things like coaching or peer support, access to mental health resources, and specific kind of targeted wellness interventions for this smaller subset of individuals. I want to highlight this wonderful paper by Dr. Sinsky and her colleagues, where they have gone through organizational evidence-based and promising practices for improving clinician well-being. And you can check this out. I have the citation, and I'll also walk through some of the key principles that have come out from this discussion paper. The idea is that the primary means by which organizations support their clinicians is by giving them the ability to do their jobs, creating workflows and structures that foster teamwork and efficiency of care. And so you can hear how the main thing that we can do to support well-being is to make sure that the systems and structures are in place so that good people can do their good work. And Dr. Sinsky goes through a set of steps for designing interventions. And this technique, this set of steps is actually pretty actionable for all of us, whether we're working at a large system in a high level leadership position and we have a lot of influence and resources, or whether we're doing one of these more grassroots efforts to self-organize and justify the need for additional well-being interventions. The idea here is that we want to be gathering ideas from multiple stakeholders, as many of the people who are involved in the process as possible. And when we can, we want to make sure that we're aiming not just to improve clinician well-being, but also patient experience, because this is going to be a real sweet spot where interventions that both enhance patient experience and also enhance well-being for healthcare providers are going to have a lot of traction. We want to make sure that we use metrics to assess the impact of the intervention. We identify where will we see the results of this intervention show up, and that we engage clinicians in planning and implementing and assessing the pilot. So we pilot interventions with small groups, we share what we've learned and iterate to improve and continue that kind of process of gathering ideas that are measurable, engaging people to plan, piloting, and then sharing the results. And one of the most difficult lessons I've had to learn as I've engaged in this work is to make sure that I'm really focusing my interventions in the center of this bubble here, in the things that I can myself and my team really control. And so as you're thinking about the interventions that you might want to launch over the next couple days. You'll be having a chance to think a lot about this. I want to make sure that we're all really thinking first about what are the things that are within our control. And then if we're talking about interventions that need to be put in place that are outside of our own individual sphere of control, then our role is actually slightly different. Instead of planning, we're going to be using our social capital, using our influence to advocate. And so I like to try to make a real clear distinction in my own head about, when I'm thinking about this well-being intervention, am I talking about something that's really within my control, in which case we can make decisions and really go ahead and act? Or am I talking about something that really requires the permission or the resources from somebody else? And then my role is much more in the realm of advocacy, where I'm trying to influence the process indirectly. I'll give you a few examples of our journey in the Department of Psychiatry. So in 2019, already that we had challenges in the area of burnout and professional fulfillment, and we organized a faculty retreat focused on wellness to try to understand, small groups getting together to identify key themes for enhancing well-being in our department. We had hundreds and hundreds and hundreds of ideas that then we distilled down into these 4 sort of areas that there was consensus were key priorities for us. So better sense of connection, belonging, and celebrating good work, more appreciation and acknowledgement of the good work that people were doing. That's number 1. Strengthening things like mentorship, sponsorship, and allyship within our department. 3rd, supporting leadership development activities. And 4th, alignment of our metrics with our core values. And so in 2019, we were engaged in work groups and leading efforts to advance action on each of these priorities. And then in 2020, we needed to pivot, honestly, although these things were so important as we mobilized for our initial pandemic response. We needed to take urgent action on some much more sort of short-term priorities. And I'll share with you a few of the things that we rolled out right at the beginning of the pandemic that were quite helpful in supporting the well-being of our people. So for instance, right in March 2020, we opened up an online listening forum. And this was a way that our leadership was able to hear from faculty, from students, from staff, right in the moments of our first responding to our shelter-in-place orders. We had 50 submissions on this listening forum in the first 5 weeks, and it helped keep our leadership informed of issues that department members were facing. We also launched something we called the Connect and Recharge groups. This was actually a surprise. One of the things we heard in our listening forum was that our mental health clinicians in our department really wanted to be able to help. I think the sense of helplessness, not being able to do anything to support their colleagues in other departments in the School of Medicine left people really eager to volunteer to help. We had our faculty host and students as well, trainees, hosted drop-in Zoom sessions based on psychological first aid principles to allow healthcare workers and other frontline workers to just check in and receive some support. We had over 50 participants in the first week and tried to scale this project up really quickly. And that was a big success for a short period of time. It wasn't something that was needed long-term as we transitioned to more stable ongoing interventions and supports, but it was a really important act that many of our colleagues generously donated their time for. We also founded a happiness hour that we actually still continue today, a drop-in opportunity for department members to just connect and support each other each week. We do this on Zoom as well. And we launched an online gratitude wall where we could share expressions of gratitude and kindness with each other. And as we've moved into 2021, we've still maintained many of these same important themes in our department. So we hear from our people that they are still really eager for opportunities for connection. So we're continuing things like the Happiness Hour. We have weekly mindfulness walks and opportunities after key meetings to connect with colleagues. We continue to hear that opportunities for professional growth are a really important wellness intervention. So we're making sure our faculty and trainees and staff have access to leadership trainings. We piloted a leadership academy this year to provide peer support for leadership development. And we're working on how to supplement mentorship and annual review meetings to further support professional growth for our faculty. We're also acknowledging that flexibility is a key aspect of well-being for our people. So things like making sure over the past year and a half that our employees have access to ergonomic equipment for doing remote work, that we're recording more and more of our key meetings to make sure that those who can't attend at the time of the meeting can view key information in an asynchronous way, and continuing to make sure to push out COVID and caregiver related resources. And then we're also pursuing local solutions. One of the things we've learned is that many of the pebbles in our shoes, so to speak, the difficult barriers to efficiency of practice really need local solutions. And so making sure each division in our department has an opportunity to pursue division-specific projects. So that's a little bit about our journey over the last couple of years. What I want to do now is shift to talk about these 6 practices identified again by Dr. Sinsky and colleagues for improving clinician well-being. And I'll go through each of these 6 and make a few comments both about what is emerging as a best practice in this area, and also about the things that we've learned and been able to implement at Stanford that my colleagues at the WellMD Center are pursuing. And also I'll make some comments about some of the small wins and lessons learned that we've had in the Department of Psychiatry. So the first one is policy, making sure that we have policies in place to support the well-being of our people, and that we periodically review policies to make sure they haven't drifted too far away, or that we don't have the sort of administrative bloat that happens when there's too many different obligations. And that relates also to efficiency of the work environment, making sure we're looking at how efficient people are able to work, and if there are changes that need to be made to streamline and reduce workload. I'll talk then after that about support, the things that need to be in place for us to be able to do our jobs, and also for us to be able to take breaks and not do our jobs when appropriate, and talk about leadership, how important the actual leadership behaviors really are for employee well-being. And finally, I'll talk about workforce assessment, what has been emerging as an extremely important aspect of understanding clinician well-being, and the type of organizational commitment for those institutions that are ready to take a big step to maybe appoint a chief wellness officer, bake in well-being initiatives into the fabric of quality improvement efforts, and make a serious commitment to organizational well-being. So here we are on the topic of policy. I love this quote: when administrative tasks are intentionally minimized, there's more time for the important work of careful listening, medical decision-making, and relationship building. So important to make sure that we're monitoring periodically whether the administrative tasks we're asking our people to do are really interfering with the medical decision-making, the relationship building, the careful listening. That's at the core of their real job. One really important note here is that actually because of the urgency of the COVID response in that sort of emergency situation, many institutions found that there were policies that could be changed really overnight or over, a week or two that had been very difficult to change before. And I think we're all at this point looking back over the last 18 months and thinking, wow, these are lessons to be learned about things that could be better if we had that kind of urgency. So, for instance, in our department, we now provide a tremendous amount of care via telehealth, and telehealth care is extremely effective in many areas of psychiatry. And we were able to pivot extremely quickly to doing that, as I know many of you probably were as well. And that the lessons that we learned from doing that are really inspiring, and breaking down some of the barriers that existed before. Will all benefit from those transitions. Similarly, focusing on efficiency of the work environment, making sure that we have a lot of clarity about what is the work that really matters and what is the more shallow work or the sort of the minutia, and how can we make sure the balance is appropriate so that we're all having the kind of impact that we have. There's also been a lot of efforts to reduce work after hours. Pajama time, we sometimes call it. But we know that clinicians who are logged in at night and on the weekends and doing a lot of work after hours are really at greater risk for burnout. So starting to look at, is there anything we can do in the work environment to reduce the amount of time, whether it's inbox optimization or scribes in the clinical rooms, or there are lots of different interesting ideas. Some low cost, some higher cost, but things that can be done to make sure that that the work can be done during the workday, and that there are times when clinicians can have time off. A couple of things, little things we've implemented in our department. Actually, for a couple of years now, we've had this initiative we call Silent Sundays. And the idea is that we ask people to please avoid emailing each other about routine matters on Sundays. If you're doing your work on Sunday, that's okay, but you can delay delivery of a message until Monday so that we're not bombarding each other with a lot of messages over the weekends. Most of the people in our department work a Monday through Friday work schedule, and so it makes a lot of sense to try to encourage each other to keep the volume of emails pretty light on the weekends. The other thing we've implemented recently, we call it the 10 of challenge. Many of you are probably doing this in your organizations as well. We challenge each other to try to end our meetings and our patient appointments at 10 until the hour, and see how many times we can do this. Challenge our colleagues to do the same. This all just gives us a little bit of a break as we're transitioning between meetings, and a much needed breather to stretch or get a drink of water, that kind of thing. Moving to the third theme, this one relates to support. The idea here is going back to how, mostly our good people just want to do their jobs, and what kind of support each of us needs to just get the work done. And then we need support for spending time away from work, and also things that help us feel connected with colleagues. I'll share a few things that ways we've thought about this. Talk about personal resilience a little bit like a recipe, where each person has their own recipe. You kind of need to know yourself and know what works for you. But once you figure out what your key ingredients are, then you can make that recipe sort of just the way you want. One of the key ingredients, and probably the recipes of many of us, relates to energy management. We find, maybe as we get older, that we don't have the energy to go all day long and all night long. And so it's important to make sure that we're going to be able to do our best work if we keep our physical health intact. So getting enough sleep, getting exercise, eating well, that kind of thing is going to manage our energy. And each of us have things that drain our energy and also replenish our energy. And knowing that about yourself is incredibly important. A second ingredient that's probably on the list for most of us is that ingredient of social connection. So we have social connection with our friends and our colleagues and our family members, both outside of work and also in the workplace. And the more we can enhance our social connection, the better that we'll all feel. And a third important component is meaningful impact. If we feel like we're able to do work that really matters, then we'll actually experience more professional fulfillment. I want to talk about one really important intervention, again from Dr. West. So I'm excited to share how much of a benefit we have had here at Stanford in implementing this camaraderie or commensality group projects. This is the idea with this intervention is that groups of colleagues, in our case, we've done it with about 6 to 8 colleagues, agree together. We did this both before the pandemic and also have had some virtual opportunities for camaraderie groups since the pandemic, where we meet for an hour once a month for 6 months. And the idea is basically first spend the first 15 or 20 minutes discussing some kind of a topic related to meaning in medicine, work-life integration, something about professional fulfillment or well-being, and then the rest of the time sharing a meal and enjoying each other's company. And impressively, just this simple intervention has been shown to increase professional fulfillment and reduce burnout. This is something, the cost, if a department covers it, is really like a few $1,000s to do this for a good number of people. Just because, if a department can support the funds for the food, then this is one of these very low cost interventions that tends to have an outsized effect on burnout and professional fulfillment. I want to mention a little bit more about meaning in work as well. So there's an interesting study from a number of years ago. Dr. Schanefeld published this study with colleagues looking at the experience of burnout depending on how much time these doctors spent in their activity that they had self-defined as their most meaningful activity. And what you can see from the data is actually really interesting. The rates of burnout are really the highest in these two groups, the groups of individuals who are spending either less than 5% or between 5 and 10% of their time on the activity that they find most personally meaningful. Once you get to about 11 to 20% of your time spent on a meaningful activity, there's a substantial benefit in terms of reducing burnout. And so it really challenges us all to think, we probably don't have to spend 100% of our time on our most meaningful activity, but if we can get in the range of 10 or 15, 20% of our time, maybe the equivalent of about 1 day a week, where we're engaged in the part of our job that we find the most personally meaningful, whether that be teaching or clinical work or research or administrative activities, whichever part of that we each find most personally meaningful, that it would be expected to have a nice effect on reducing burnout. So it's a good moment for each of you as you're listening to think, which aspect of your work do you find most personally meaningful? And what percentage of your time are you currently spending on that role or that project? If it's less than about 5 hours a week, what would it take to increase this? And for those of you in leadership roles or who are supervising other people, make sure you know which aspects of your employees or your trainees' roles they find most personally meaningful, because anything you can do to increase the amount of time that your employees are spending on the things that they find really matter, the better that will be for their sense of professional fulfillment. I've created this little table because I like to remind myself that actually my mindset really matters here. I could feel pretty burdened with the requirement to do timely documentation, but if I try to remember how that burdensome task contributes to an outcome I really care about, that can also help me connect that work with something more meaningful. So I know that timely documentation really enhances patient safety, and that's a critical component of quality care, and that I care about. I might feel burdened covering for a colleague on vacation, but actually I want to be sure that I work in an organization where it's possible to take time off. And so when I cover for a colleague, I'm contributing to that culture of wellness. Giving difficult feedback to a struggling trainee might be something that I am reluctant to do, but actually I care a lot about helping a new generation of professionals get ready to do important work in our field, so I can get myself connected to the meaningfulness of that task. Responding quickly and with compassion to a patient complaint, I might feel like I want to avoid that task, but actually that fosters the kind of culture of excellence that I'm proud to be part of in my organization. And responsible management of finances helps us serve more patients who are unable to pay. So I think it's useful for each of us to think about, well, are there aspects of my work that actually feel like kind of a drag, but are really connected to an important part of the meaning? And the more that we can talk with our colleagues and with our employees about the meaningfulness of these difficult tasks, the more we can connect it to a sense of professional fulfillment. I'm going to shift now to talk about a fourth component, which is leadership. There are really emerging and nicely well accepted practices for effective leadership, including shared accountability that I talked about before, where everyone in an organization is really held responsible, even at the highest executive level, held responsible for clinician well-being metrics, and the distributed leadership that I also have talked about how those people who are really empowered across the organization to take action on the small things, to gather input from stakeholders and pilot projects that will improve well-being for individuals. And the balance of that shared accountability, that distributed leadership, and balancing things like standardized workflows to improve efficiency, but also customization to recognize the inherent uniqueness of certain specialties. This is the challenge for our leadership. There's a really important emerging data about how leadership matters for well-being. So here's a study from 2015, employees who supervisor leadership behaviors more favorably also report lower rates of burnout and higher job satisfaction. That's extremely important to know. In addition, here's a study from just this last year, looking at how shared purpose and personal organizational values alignment between leaders and teams really are important for physician well-being. And then finally, a study also published in 2020 showing that burnout, professional fulfillment, and self-care practices of physician leaders appear to be associated with their leadership effectiveness. So those of us who are in leadership roles really need to model the self-care practices that we want our employees to take to do themselves. And finally, to talk a little bit about trainees, Lottie Derby and her colleagues have published extensively on the importance of well-being interventions and the experience of residents and other trainees. But here's an important study published last year showing that the relationship between residents' perceptions of their residency program leadership team behaviors was related to resident burnout and satisfaction. So here's the leadership score on the y-axis, and on the x-axis, I feel burned out from my work. And you can see that the lower burnout is associated with a higher leadership score, and the lowest leadership scores are associated with higher rates of burnout in these residents. And similarly, overall, how satisfied are you with your residency program seems to have a pretty strong relationship with the leadership score, where strongly dissatisfied individuals are rating the leadership score quite low, and very satisfied individuals are rating the leadership high. Here are a few leadership strategies. These are the ones that have been measured in many of these studies. And I put this up here because actually it's great for us all to reflect on. Most of these are quite actionable, do not take a lot of resources. These are the things we can encourage ourselves and each other to do. Things like expressing interest in the opinions of our team members, encouraging people to suggest ideas for improvement. Showing respect, so treating others with respect and dignity, and keeping people informed about changes that are taking place within the organization. Empowering people to do their jobs and providing helpful feedback and coaching on performance. Recognizing people for a job well done and inspiring team members to do their best. And finally, holding career development conversations and encouraging our people to develop their talents and skills. So as you look at this list, I would ask you, which of these characteristics do you value most in your leaders? Are there things here that you can, can point out and say, oh yes, there's a leader that I really admire who, consistently shows this behavior? And similarly, is there a list that you would want to cultivate more of? Do you see something here that you might aspire to do more consistently? These are the kinds of leadership behaviors that don't cost much, but do have a disproportionate effect on the well-being and professional fulfillment of the people that we work with. I'll turn now to mention the idea of workforce assessment. So this is increasingly considered a best practice for organizations that want to improve clinician well-being. And there are lots of ways that well-being can be assessed. We can ask people directly using validated measures of burnout and professional fulfillment. So surveying people directly. We can also look at things like I talked about before, costs like the turnover, how many people are reducing their clinical hours and sort of start to quantify the costs of burnout. We can look at electronic health record metrics. There's increasing interest in this, and we have big data sets that can be really capitalized on for this purpose. So understanding, like for instance, at Stanford, we have a metric that captures clinician number of hours clinicians are logged in after their clinic hours, the clock metric, which is a way to capture that pajama time and understand, do we have interventions in place that are decreasing the amount of time clinicians need to be spending on nights and weekends doing documentation. We can measure other aspects of the efficiency of the practice environment. We can measure things related to behaviors of leaders or things like about organizational culture. At Stanford right now, we're engaged in an effort to understand experiences of mistreatment and developing interventions for that aspect of culture as well. On the topic of assessment, I'll highlight the work of some of my colleagues from the WellMD Center and their colleagues across the country who have put together the Physician Wellness Academic Consortium. Right now there are 19 academic affiliated member organizations, and the goal of this consortium is to advance well-being of physicians and those they serve. They've been doing occupational wellness assessments using a Stanford doctor survey that assesses professional fulfillment and burnout and their key drivers. And they're trying to use measures that are efficient, reliable, and sensitive to change. And this has been administered at Stanford over a couple of times over the last few years. So both in 2013, 2016, 2019, and most recently in 2020, using specialty-specific benchmarks that are drawn from the members of the consortium and longitudinally linking the data and trying to share best practices and support chief wellness officers and wellness leaders from member organizations. So in the Department of Psychiatry, for instance, we've learned a lot looking at how burnout and professional fulfillment have increased over the last few years, and using that to really advocate for system level solutions that we need for our people. So for instance, we've put in place this year more of a systemic approach. Our chair has asked for the establishment of a new advisory committee that's a standing committee that reports directly to the leadership in the department. And we've taken our survey data from our clinicians and faculty, and also qualitative data that we have documenting increased burnout, and also from listening sessions where we're opening up for people to drop in and talk to us about what is going on that's affecting their well-being. And we follow this sort of ask, listen, empower cycle where we find out what the problems are, we listen to what they are, and then we try to come up with solutions and empower small groups and teams to innovate and do specific action. We're working, like I mentioned before, on things like connection and belonging, and things like redesigning our workload and supporting caregivers. And as we were engaged in this work, we couldn't help but notice a reality this last year that many of you faced as well, where many of our workers were working in this idyllic set of circumstances. And so we also went and did some additional assessment to try to understand what were the barriers that our employees were facing related to their caregiving responsibilities. So we did a survey. We got responses from about 116 caregivers in our department. And we learned, this was done in June of 2020, we learned that we had 81% of our people working into the evenings and into the night more than they previously did. We had, we had 59% of our people wholly or partially responsible for the homeschooling of school-aged children. We had, really impressively, this was a shocking number. At that time, only 14% of our faculty and staff and trainees who responded to the survey had hired any caregiving assistance because of their probably fears related to the pandemic and COVID transmission. And these data helped us to launch a really impressive pilot program just to show what you can do with very few resources, but a lot of gumption. We launched something called the Virtual Child Engagement Program. We had volunteers from our research, many of them were research assistants and individuals who themselves didn't have children, but were sheltering in place, maybe even living alone, and couldn't do aspects of their job, their regular job, during the initial phases of the pandemic. They volunteered to get online with the children of our faculty and staff. And we trained them to engage those kids with developmentally appropriate activities. And believe it or not, we've done 2,215 of these sessions completed to date. So what started out as just a tiny little program, just kind of a whim to see if we could help a little bit, has been a tremendous help to parents of young children. And the program has been extremely popular. And more broadly, this information led us to disseminate some best practices for supporting employees who are caregiving. So we really pushed out a lot of messaging in our department about how we were encouraging managers and supervisors to demonstrate compassion, to explicitly express understanding, saying out loud that they support their employees' caregiving roles, really revisit assumptions about meeting formats that worked before but might be ineffective in a remote work environment, and really prioritizing asynchronous communication and only requiring face time when it's really needed. So these are some examples of the messaging that we put out that hoping to support our caregivers. And the final point I'll make, the final sixth component of the best practices for supporting clinician well-being really relates to an organizational commitment. So hopefully many of you are in organizations or in leadership roles where you're ready to move forward with making a stronger organizational commitment to physician or clinician well-being. And there's this really influential and important charter on physician well-being that you can check out this JAMA article by Thomas Ripon West in 2018, and many institutions across the country have signed on as participants in adopting the principles of this charter. And I would encourage you to check it out if you haven't seen it already. There are some really useful principles for how to move forward with organizational commitment to well-being. And it's going to include things like establishing program, appointing a chief wellness officer who's an executive with real leadership responsibilities, and making sure that measures of well-being are embedded in the strategic plan. If you're interested, Stanford annually hosts a Stanford Medicine Chief Wellness Officer course, which is really designed to train future or existing chief wellness officers. This just took place in Half Moon Bay in June, and it typically takes place annually, but you can check that out on the WellMD website. And I'll add a few additional resources here that might be of interest to many of you. So I mentioned the Stanford WellMD Center. There's a wealth of resources available there. You may also want to check out the National Academy of Medicine Clinician Wellbeing Knowledge Hub, another wealth of resources there that you and people in your organization may find to be useful. The Greater Good Science Center at UC Berkeley puts out a lot of resources, both related to organizational well-being efforts as well as personal resilience supports. So a great place to check out. Last year, I worked with the Stanford Center for Health Education and launched a course, a 6-week online short course related to employee wellness and stress management. You can be welcome to check that out as well for any individuals who might be interested that to take that course. And here I've put a few books that might be of interest to people attending. This one in green called Professional Wellbeing is the book that Dr. Gotham mentioned I wrote with several of my colleagues here at Stanford last year. There's a tremendous book about strategies to reduce burnout from Dr. Swenson and Dr. Schoenfeld that came out earlier this year. This is a really important kind of guide for organizational level interventions to reduce burnout. And some great books, both for the individual, some of my favorites, Essentialism, Deep Work. There's one called Overwhelmed and one called Burnout. Lots of really great information about how each of us can do our very best work. So I'm going to conclude with two kind of reminders. This is one thing that I try to remember myself. We mostly talked about systems today, but systems are made up of people. And, we're not going to fix the problem of clinician burnout if we're each burned out ourselves. And so I try to remind myself that as I'm trying to combat burnout, that when we tackle hard problems, and the problem of clinician well-being and burnout is one of the hardest, you will get discouraged. Whenever anyone innovates across industries, we will encounter resistance, and some of our ideas will fail. And that's okay. The secret of success, in my mind, seems to be to keep your body, your mind, your heart physically, emotionally, intellectually prepared to be resilient when we face challenges. And we have to remember that there's no one right answer for everyone. So the better you know yourself and you know what works for you, both what drains your batteries, but also what inspires you and gives you energy, the better you can move forward. And then at the system level, I'm trying constantly to remind my colleagues that wellness is not a soft and fluffy idea. The reason that we care about clinician well-being is because it drives meaningful impact on our mission. We are going to be able to do the important work that we do better and faster and stronger if we are making sure we're taking care of our people. So we try to hold that care for people always idea in our minds. and really put in place a system where everyone can help. All ideas are welcome, but we acknowledge that the well-being of our colleagues and our employees is not an individual problem. It's a problem that the system needs to care about, and that leadership actions, everything we do in terms of leading an organization, matters in driving clinician well-being. And well, if we remember that well-being is a part of quality improvement, healthcare systems have made tremendous strides over the last few decades in quality improvement efforts. And if we can take what we've learned from those efforts and start to embed well-being as part of quality, then we can really move forward in a positive way. We're trying to remember today and tomorrow that flexibility is going to allow our people to optimally recover and recharge, and that if we can help foster collaborations, which this symposium 2 days will be a great opportunity for that, collaborations really enhance professional fulfillment and our sense of connection. Thank you very much for listening. I hope you've been inspired to take the next steps in your organization to improve professional fulfillment and well-being. And I look forward to discussing more in the Q&A.
Thank you so much, Dr. Gengoux. This was, I'm going to echo some of the words in the chat, filled with very, very, very helpful, useful information. Just an introduction for those of you who don't know who I am. My name is Brandy Clark, and I am the project director for the Mid-America Mental Health Technology Transfer Center. And I'm going to help moderate our Q&A today. So if you have any questions for our presenter, please add those to the chat or the Q&A pod. We've been getting some questions coming in as we've been going through this session here. But again, as I mentioned, a lot of very, very helpful information, nuggets, reminders, models, and strategies that we can learn from. And some of the questions that we've received thus far are very much related to those things about the implementation of some of the strategies that you mentioned. And I think also reflect to people's thinking about how to do these things with some of the changes or shifts we've experienced related to COVID. So I'm going to just read through a few of these here and to get your thoughts on and share how these things were implemented. So first question that we have is related to the gratitude wall and how that was implemented. So how do people add submissions? What kind of program was used? And I know we've seen some of these in person on a physical wall space, but maybe also if you could speak to how in a virtual setting, if we're not in the same environment, how that might work as well.
Yeah, absolutely. You're right. We had a physical version of this before the pandemic. We had printed out, gratitude cards that people would be able to give each other. We'd bring them to meetings, and we're doing this as an intervention, but it was all really pretty physical. So the gratitude cards would be, put in someone's mailbox or posted on a bulletin board, probably like many of you have done. And there's probably lots of different ways to build this in a virtual format. I'm sure lots of people on the call can think of more creative ideas than I have. We created a little like a Qualtrics survey. So if there's just a link, so there's a link that's posted on our internal intranet website. And so you can click on the link and you basically just type in, the thing that you're grateful for. And then that is then posted on an internal website. So other people can read it. But we've also experimented with, more like a Google Drive kind of document that's shared and where people can post either images or text. So lots of kind of ways to do this. Whatever system you're using within your organization, we took advantage of the fact that we have an internal department intranet page that's really frequently accessed, and that seemed for us like the best place to do it.
Excellent. And so those submissions, it sounds like there was a submission form that people could go and access at any point in time.
Yeah.
Perfect.
Exactly.
Our next question is related to social connection projects. And I know during this period of the pandemic, that's one area that's been a bit of a challenge. We've been seeing some hopeful opportunities but also recognize that we're in this constant state of flexibility with that and responding to needs. So the next question that we have is, how do you handle the social connection projects like the Friday Happiness Hour in light of social distancing requirements? Virtual meetings of the group just don't seem to be as helpful for well-being in comparison to our in-person meetings.
Yeah, this is something we've all been really struggling with. And, we were really enjoying before the pandemic, these camaraderie groups and that, those in-person meals and things were really a source of connection. We've tried lots of different ways to connect online. The Happiness Hour is an online thing. It's a virtual drop-in link. And, that's been useful for some people, but a small number of people typically attend. I think a lot of my colleagues have found that the better ways to connect are when people are feeling so busy and so stretched thin, one more Zoom call seems like just too much. So a couple of the things we've found useful. Number one is in some of our key meetings, like for instance, in the division meetings that I attend in our child division, we've designated the last 10 minutes of the meeting as social time. And so we put people into breakout rooms, and it's totally optional. If you'd rather just sign off early, then that's okay. But lots of people have really appreciated that. So, ending a 1 hour meeting, we try to cram it all in about 40 minutes. And then we get, from 12:40 to 12:50 is the connect with colleagues time. And then you can still sign off for your 10-minute challenge. So you can use the bathroom, get a drink of water, find the link to your next Zoom meeting, et cetera. So making it a part of existing meetings, I think, is really a key if you're having trouble getting people to attend at a separate time, whether it's because of a check-in or we've done some polling and some fun activities, just kind of like icebreaker type things at the beginnings of meetings too, and that seems to help. And then, we are looking forward to small opportunities to get back together in person when that's safe. So some of that, of course, we'll all be eager when that's easier to do.
Yes, most definitely. And I think you answered this next question somewhat within your response here, but I don't know if you'd have anything explicitly to add to this. So regarding some of those projects, were they on the social connectedness projects? Are they on paid time? Are they built into the job day, if you will, the work day? Yeah.
This is a really important question and kind of a complicated one to answer because every department and every organization has the pay structures sort of differently. So in most cases, these are happening during the 9 to 5 workday. In our department, we have clinicians who are, accountable for productivity targets, and with very few exceptions for things like the Leadership Academy. So certain kinds of activities we've been able to get, official kind of buyout of our clinical time. But for things like the Happiness Hour, there isn't a buyout of clinical time, but people are welcome to attend. And I think that, one important, there's, whether you're paid for the time or not, but there's also, whether there's explicit leadership support for taking breaks and for connecting with colleagues. And, we've been lucky to be able to really explicitly acknowledge out loud, in big town hall meetings, in our biweekly newsletter, in public communications, that we consider connecting with your colleagues part of the work. So this is a part of your workday. And if what you're doing is supporting somebody, you can imagine, but in the Happiness Hour, there's some goofing around, there's, family members are allowed to attend, but there's also serious discussion of mentorship and leadership challenges. And, we're all kind of nerdy when we get together. We often talk about work, and it's very useful to acknowledge at the highest levels in an organization that supporting each other and interacting with each other and building relationships with your colleagues is part of the work. That makes us better at our jobs.
Excellent. Thank you for that. The next set of questions is somewhat related to the topic that you mentioned, related to paid time and cost and funding for these activities. And so one of our questions is specific to having access to or suggestions for the low cost projects, resources, things that nature. You mentioned a few of those. Is there a place where folks can go to access that information, or other examples that you might have related to low cost solutions?
Yeah, definitely, check out the WellMD website. I think that book, Dr. Swenson and Schoenefeld's book from the Mayo Clinic, the 12 strategies to reduce burnout, many of those are very, very low cost intervention strategies. So it's useful to check that out. Probably the best idea is to get together a little group of people who care about this issue and brainstorm ideas that you think, are within your sphere of control. What could you do to make your work better? And start with a little project. The smaller you start, the more likely you'll experience success. And the people in your organization are going to know best what are the things that are going to make the biggest difference. And, start with one little thing that people agree might make a teeny difference and see how that goes, and then kind of iterate from there. And in many organizations, both this is the experience we've had in our department and other departments that I am aware of, my colleagues, when we start small like that and we get some success, it starts to demonstrate, it starts to sort of get a groundswell going where this is one of the ways that we can advocate for more financial resources and more serious commitment from leadership, is by showing that the little things that we do make a difference, and that people are engaged and motivated to take action on these items.
Excellent. And another question that came in just related to this, and one that actually is in my mind too, are these conversations around funding.
Yeah.
And getting folks on board with seeing the cost benefit to this programming. So the question is, with executive leadership and board members, often money talks.
Yeah.
And so any tips for influencing top-down support for implementing strategies that might seem counter to productivity incentives or requirements?
Yeah. Well, pilot projects are, speak a lot, but I think you can also rely on some of the resources that I mentioned, the publications that I cited and that have come out recently, because as I mentioned, there is consensus across the country about the importance of serious investment in well-being efforts. And you can, if you're in a position where you're advocating to your executive leadership, you can turn to some of the examples at institutions across the country and talk about how more and more hospitals, more and more universities, more and more community agencies are starting to recognize that the cost of burnout is too high to bear, and that things that we can do to support our people do contribute to the core mission of the organization, that the more our workers are engaged, the better work they'll do. And so turning to, examples at Stanford, it was, I think, honestly, it was the data about turnover. It's too expensive to replace skilled doctors and healthcare providers to consistently have to replace them. And so if there are things that we can do to keep the good people that we've trained and help them to do the good work that they are trained to do, it's worth it to the organization.
Excellent. I think we're nearing the end of our time here for this first presentation, but I couldn't think of a better one to start our 2-day event here. This was fantastic. And again, I'll echo the comments throughout the chat box. Thank you for the presentation. Thank you for the information, the resources. I will remind everybody they are going to be accessible and available to you, the slides and the recording both, within about a week after this presentation today. So before we move on to our next presentation, we do transition between our Zoom links, and that does allow each of our presenters to be able to prepare in advance. So our next presentation for today will be taking an equity first framework, sustainability and diversity and inclusion efforts by Dr. Ashley Stewart. And you will see the Zoom link posted here. You should have hopefully also received that emailed to you, but you can find it on your brochure and in the link here. I believe we will also post that here in the chat box for you so you can access it that way. So we will have a brief, about 10-minute transition before our next session starts, depending on your time zone there at 9:40, 10:40, 11:20, or 12:40. I believe that's supposed to be 11:40. We've passed our 11:20 timeline. So I, again, just thank you, Dr. Gengoux, for all of this incredible information. And thank you all for engaging with us today. And we look forward to seeing you in our next session.